Welcome to another video from the Heart Factory. This video is an addition to the arterial cannula video which I posted last week in relationship to the cardiopulmonary bypass, and we'll be talking about the technique of arterial cannulation in relationship to cardiopulmonary bypass. So I'll be showing you cannulation of the ascending aorta for valves, for CABG, in minimally invasive cardiac surgery, in pediatric cases as well, and a short video about the cannulation of the femoral artery as well. And we'll conclude the video with the pros and cons of each technique, what one should look at in each of the techniques, or one should be careful at whilst using each of the technique. And we'll finish the video with the complications of arterial cannulation in cardiopulmonary bypass. The first few minutes of this video will have some technical details about the arterial cannula, which I've already described. But there is something called the concept of M, which is an old thing, but I just wanted you all to know what this M, which is a single unitless number in relationship to the arterial cannula, and I hope it will be helpful for all of us in future. Arterial cannulae connect cardiopulmonary bypass circuit to the patient and are meant to acquire the required flows without increased gradient at the tip of the arterial cannula. And the type of the cannula is chosen based on the body surface area and the cardiac index. Sometimes they are chosen based on the weight as well. Either way, the amount of flow that is required, both minimum and maximum, is determined, and a particular cannula is chosen so that the maximum flows can be achieved without increased gradient at the tip of the cannula. Now, what is an increased gradient? Anything more than 100 millimeters of mercury at the tip of the aortic cannula is said to be an increased gradient, and an increased gradient will lead to hemolysis, protein denaturation, and injury of the aortic intima. Aortic cannula is usually described as something which is either a single piece or with a connector. It can be right-angled, curved, or with a straight tip. The tip may be steel or PVC plastic, and with or without a flange. It may be wire reinforced or just plain, with or without a marker that would show the direction of the tip, especially when the tip is right-angled or beveled or just curved. It always shows which way the tip has to be directed to allow flow into the arch. Basically, a curved or a straight arterial cannula is made for use in the ascending aorta, and therefore will always have a marker, and one has to make sure to see the marker which way it has to face to have an optimal and good flow from that arterial cannula. There's always the size shown on the cannula in French. And French means nothing but the circumference of a circular catheter, which is described by pi d, and therefore it means external diameter of the cannula itself. But the fallacy of the French is that it only describes the external diameter of the cannula. It cannot describe anything about the flow characteristics that would depend on the size, shape, side holes, or if there are bends and length of the cannula. Two cannula of the same French are not said to have the same flow pressure characteristics. What I meant to say is two cannulas of same French size from two manufacturers will tend to show different flow pressure characteristics, and this seems to be very important, especially in infants and children, where every bit of information about the cannula seems to be useful. Therefore, a new concept called concept of M is emerging, which is nothing but a single unitless number that describes the performance of the cannula based on the flow and pressure relationship, and is said to be the same for all cannula of different makes across any French sizes. Now, what is this M? This M is described in a paper published in the Annals of Thoracic Surgery in 1992 by Delius et al. And the concept is taken from the Reynolds number, which is a friction factor correlation, and you can find the M number for a given particular cannula from a nomogram. And Any cannula of any make with the same French will tend to show the actual pressure flow characteristics of the cannula and is said to be useful in future in selecting the cannula. So that M number is nothing but a pressure flow relationship of different cannulas, which should be constant for all the cannulae from different makes for the given French. Now coming to a right angle tip cannula, the cannula, especially with the steel tip, there is an importance of something called the ID/OD ratio. A better ID/OD ratio would give rise to a greater flow at the tip of the cannula with lesser pressure gradients and lesser hemolysis. A connector or a flange on this arterial cannula is meant to be hemostatic. It allows you to fix the cannula and the aorta and also stops the cannula from entering too much into the ascending aorta. Mind you, this cannula is meant only to be used on the ascending aorta. It is a beveled opening, so therefore it tends to give a jet flow. Whenever there is a jet flow, what happens is the jet can either hit the posterior wall of the arch or the ascending aorta and give rise to shower of arterial emboli. If they are there at that point of hitting the aorta, it can selectively cannulate the neck vessels. If you tilt the cannula too much, it can give higher gradients, or the perfusionist may complain of obstruction to the aortic cannula. But the advantage is that it will not injure the posterior wall. A better ID/OD ratio, as you said before, will give rise to a lesser pressure gradient that is less than 100 millimeters of mercury. That is what we expect for all aortic cannulas at the tip of the cannula. A right angle cannula, it can be better steadied on the ascending aorta because of the flange. Having said that, an angled tip will always give rise to a higher pressure gradient compared to a straight tip cannula. But the only advantage of an angled tip is that it will not injure the posterior wall of the aorta. You have to be careful that you are not directing it towards the aortic valve, lest on applying cross clamp you may get a higher gradient or the perfusionist may complain of higher gradient, in which case you have to turn the cannula within the aorta towards the arch, and this would be possible only when you are in the lumen of the ascending aorta, therefore 100% or 10% eliminating the risk or appearance of dissection, which is iatrogenic. And as you can see here, the beveled edge and the thin or the ID/OD ratio, you can appreciate that in this particular image, a better ID/OD ratio will give you a thinner edge to the bevel, less gradient, higher flow. Now once the cannula is in the ascending aorta and with the help of the marker you are directing it towards the arch, you can release the clamp on the catheter which comes with the clamp. The nursing staff gives you with the clamp, and then you can deair it and connect it to the CPB line, the arterial line of the CPB circuit. Now coming to the straight tipped wire reinforced arterial cannula, what you can see here, it is a single cast. There is no connector. No connector means less risk of air entrapment, no question of air embolism. So it's a wire reinforced. There are 1 centimeter marking on the cannula which will tell you how deep you are in. There is a stellate, the conical one you can see at the tip. That is, the stellate has a hole at its tip so that you can pass a guide wire and use Seldinger technique to pass this catheter in real clinical situations. As usual, there are markings on the cannula in terms of French, which will tell you the external diameter. There's a knob. This comes with knob or without a knob. A knob helps you in deairing the cannula if there is air, and if you use it to the peripheral circuit, you can measure the line pressure, which says either you're on the true lumen or false lumen, especially in dissection. Now when you put this cannula in the aorta, when you remove the stellate, you have to clamp the aorta, the line beyond the wire reinforcement, lest there will be bleeding. As you can see here, once the stellate is removed, there is a big hole, so there will be a lot of bleeding. So you have to clamp beyond the wire reinforced area once the stellate is removed and then deair the line. Now the straight tip, as you can see here, the advantage is it gives less pressure gradient, but the problem, if you assume so with this cannula, is that you can injure the posterior wall of the aorta whilst insertion if you are not careful. So you have to mark. Keep an eye on the marker regards how much deep you are in the ascending aorta. Now you can use it by Seldinger technique as well if you are using this, so you can use a guide wire and then set the cannula over the guide wire. Now coming to another form of cannula, as you can see here, it's a single cast, no connector, curved plastic arterial cannulae. But here the marking is away from the anesthetist, that is towards the foot end of the patient. As said before, you should always watch for the marker. It can be directed towards the arch or away from the arch, and based on the marker you have to place the cannula within the arch to have optimal flow from this cannula. It's not wire reinforced. It's likely to get a bit supple as the case progresses because of the patient getting rewarmed. So marker in this particular cannula is away from the head end of the anesthetist. So one has to really make note of the marker and place the cannula accordingly to have optimal flows. Again, a beveled edge, which is meant for the arch flow. This cannula is meant for the ascending aorta, as always has to be directed towards the arch. Now a much leaner types of arterial cannula, the one we use for pediatric, wire reinforced with markings 1 centimeter apart, beveled tip cannulas, and you can see the stillet is a bit broader at the below and thinner at the top, so that there is no bleeding when you put this cannula in the ascending aorta. Because this cannula is more slender and wire reinforced, you can still use this cannula for use in interjugular vein, especially with the outburst of mixed cases. You can still use this cannula for interjugular vein as well, not necessarily that it has to be used for arterial. This is another type of cannula, as you can see, not wire reinforced. It is well marked. It has a beveled tip. It's a single cast. Again, you can see there is place for the snugger to be tied whilst the cannula is in the ascending aorta. You can see there is room for the cannula to be tied with the help of the snugger. Beveled edge means jet flow, a bit higher gradient, but again this is a straight tip cannula. Let's use the posterior wall, may give atheroma shower, but again you have to fix it very carefully. There's a marker is away, as you can see the marker tells you which way it has to be directed. The same thing with this cannula as well. Marker tells you which way the cannula has to be directed, only difference being this is wire reinforced. Any cannula that is wire reinforced allows you to give a larger room within the cannula, a thinner wall, kink resistant. That's all is the advantage of wire reinforcement. Thin walled, larger room, kink resistant. And as the patient gets rewarmed, the cannula gets supple and more prone for kinking. So wire reinforcement helps in cannula not getting kinked. Now coming to the femoral cannula, as you know, it is a peripheral cannulation. Peripheral cannulation can be done either with the femoral artery or the axillary artery. So this is a femoral arterial cannula which is wire reinforced. The markings on this will be at 5 centimeters apart. The distal end will have multiple holes. The wire reinforcement is for a longer duration or longer length of the cannula. You have a knob at the distal end or at the outer end, which you can either deair or measure the line pressure, especially when it is a case of dissection. The arrangement is such that you can use this cannula by Selding a technique. Now you should be knowing what are the actual steps of Selding a technique. There are multiple side holes at the end of the cannula so that it gives kind of a dispersion or diffusion type of a flow rather than a jet flow. But the main thing here is the flow is retrograde. When you use the femoral cannulation, the flow is retrograde. It is not physiologic. Physiologic is antegrade flow. The flow is retrograde. You can have larger shower of arterioemboli that would be there in the abdominal aorta or the thoracic aorta into the brain when you use a femoral cannulation. But it also seems to be a very important means of cannulating or means of establishing cardiopulmonary bypass, especially in patients who are undergoing minimally invasive cardiac surgery, radiocardiac surgery, in patients who have dissections, especially type A dissection, and you are in emergency for gross aneurysm of the ascending aorta, in emergency situations, almost all of the extracorporeal membrane oxygenation cases, and also in situations where the aorta is not amenable for cannulation, like the porcelain aorta, you can always go ahead and cannulate the femoral artery. Mind you, a preoperative CT aortogram of the ascending aorta, arch, thoracic aorta, descending aorta is or would be an absolute must just to make sure that there are no gross atheromatous changes that are there in the abdominal aorta. More atheromatous changes, more risk of stroke or shower that is going to the brain because of the retrograde or antiphysiologic flow from the femoral artery. Having said this, you can also cannulate the axillary artery. Now, the axillary artery cannulation will always give rise to antegrade flow. The axillary artery is less prone for arterioemboli. There is less risk of infection and dissection when you use an axillary artery. Now, the axillary artery is usually cannulated by means of a graft, a 8 mm kind of a graft is sewn into the axillary artery. Then the graft is cannulated for antegrade perfusion. So when you are done with the case, the graft is then divided just above the artery and over sewn. So compared to a femoral artery, the axillary artery uses, especially in dissections or in aneurysms, gives you more antegrade flow. There are more advantages like forward flow, less arterioemboli. But having said that, any peripheral cannulation, you can have thrombosis with that particular artery, you can have embolism from that particular artery, you can have infection of that particular site because of exposing that particular artery. So depending on the situation or depending on the type of cannulation, the type of cannula is chosen. So not the right angle cannula cannot be used in periphery and peripheral cannula cannot be used in the ascending aorta. Now coming to the newer cannulae, now all the cannula which we described now, till now, we are giving jet flow. But the newer cannula are designed in such that they will give you diffusion type of flow and some are giving dispersion type of flow as well, all meant to reduce the sandblasting and jet effect of a well-edged cannula or an end hole cannula. The problem here is they are a bit difficult to use and may produce a bigger hole in the ascending aorta. Now coming to the actual steps of cannulating the ascending aorta, you have to first take the purse string on the aorta. Now as I said below, the cannula is chosen based on the body weight or body surface area